Hello, and welcome to Adjunct Periodontal Therapies Lecture 4, Antibiotics, by Brittany Jones. Using information from your pre-reading, Adjunctive Use of Antibiotics in Periodontal Therapy, please discuss the following questions. What is the rationale for administering antibiotics in adjunct periodontal therapy? What are the advantages and disadvantages to systemic antibiotic therapy? What type of patient would likely benefit from systemic antibiotics? Table 1 lists pathogens associated with periodontitis. In today's lecture, the pathogens affected by each antibiotic will be addressed. Below are some abbreviations used in this lecture. Pocket depth, abbreviated PD. Clinical attachment level, CAL. Plaque index, PI. Other abbreviations are the shorthand versions for different bacteria. You have been provided with a partially completed chart about the antibiotics that we will discuss today. There are many antibiotics used in periodontal therapy. The following will be covered in this lesson: tetracycline, minocycline, doxycycline, azithromycin, cetronidazole, metronidazole, metronidazole and amoxicillin, moxifloxacin, and ciprofloxacin. Please fill in the chart as we go through this lecture. Tetracycline is a bacteriostatic antibiotic, which means that it stops bacteria from reproducing rather than killing bacteria. It is widely used because it is able to achieve very high concentration in gingival crevicular fluid. Tetracycline is effective against Actinobacillus actinomycetin comitans, Campylobacter rectus, Eikenella corrodens, and Capnocytophaga. Tetracycline can be administered orally or locally. When administered orally, the patient is given 250 milligrams 4 times a day. It has been known to be effective in the treatment of refractory periodontitis and localized aggressive periodontitis. Side effects of orally administered tetracycline include intrinsic tooth staining, gastrointestinal upset, and fungal overgrowth. The product used to locally deliver tetracycline is called Actisite. It presents in a 0.5 millimeter fiber inserted into the pocket. Actisite has been known to improve healing, namely in the reduction of periodontal pocket depths, bleeding on probing, and gain in clinical attachment level. Side effects of Actisite have been reported to be local erythema, occasional systemic reactions, and oral candidiasis. Minocycline is a semi-synthetic version of tetracycline and therefore is effective against the same bacteria. It can be administered orally at a 100 milligram dose twice a day. A side effect reported is vertigo. It is also the only type of tetracycline that can discolor permanently erupted teeth. Minocycline has shown to be similar in effectiveness to tetracycline, but is more effective against gram-negative facultative anaerobes. Minocycline can be delivered locally in the form of a Rustin, a 1 milligram minocycline microsphere, or in a 2% gel. A Rustin is effective in chronic periodontitis. A randomized controlled trial of 2% minocycline gel did not show significant improvement versus SRP alone. However, a meta-analysis of several studies showed decreased pocket depths, but no significant clinical attachment level gains. Side effects of Arrestin: post-marketing cases of anaphylaxis and serious skin reactions, such as Stevens-Johnson syndrome and erythema multiforme. Doxycycline is also a form of tetracycline and therefore affects the same bacteria. Doxycycline can be administered orally with a 100 milligram dose once a day. This is a perk to the drug and makes patients more compliant. Doxycycline orally has shown to decrease pocket depths, increase clinical attachment level, but has not shown a change in bleeding on probing. Doxycycline can be delivered locally, either in the form of Atrodox or in a 2% doxycycline hycalate gel. It has been found that there was a significant decrease in pocket depth and increase in clinical attachment level. However, there was no significant difference in plaque index. The side effects of doxycycline include colitis, diarrhea, gastrointestinal disease, inflammatory bowel disease, and photosensitivity. Azithromycin can be administered orally in a dosage of 250 to 500 milligrams once daily for 3 days. It is highly effective against all types of AA and against P. gingivalis. Azithromycin is often used to treat chronic periodontitis. Side effects include nausea, abdominal pain, and angioedema. Satronidazole is administered in a 3% subgingival gel. No adverse reactions have been found for satronidazole gel. In a study by the Department of Periodontic Government Dental College and Research Institute, the mean pocket depth readings of patients with satronidazole gel administration were significantly improved compared to SRP alone. Clinical attachment levels were also increased. The bacteria affected most by satronidazole include P. gingivalis, T. forsythia, and AA. Metronidazole, more commonly known as Flagyl, is effectively used to treat acute necrotizing ulcerative gingivitis, refractory periodontitis, and adult periodontitis. It is administered orally at a dosage of 200 to 400 milligrams 3 times a day. Side effects include cramps and nausea, also vomiting following alcohol consumption. It is contraindicated in patients taking lithium or using anticoagulants or in patients with a history of seizures. Metronidazole can also be administered via a Lysol gel, a 25% metronidazole benzoate, which is bioabsorbable. The combination of metronidazole and amoxicillin is commonly used in the treatment of periodontal disease. The bacteria most affected by this combination are AA and PG. One study showed that AA was eliminated in 97% of patients. The combination of metronidazole and amoxicillin has been shown to improve pocket depths and clinical attachment level, as well as bleeding on probing. These two drugs are administered at a dosage of 500 milligrams each 3 times a day. It has been indicated that this combination yields better results than each of the drugs administered separately, as well as being more effective than doxycycline. Moxifloxacin is effective against a broad range of bacteria. When administered orally, it is given to the patient once a day in a 400 milligram dose. Moxifloxacin is comparable to SRP alone when it comes to plaque index and bleeding on probing. However, when it is administered in adjunct periodontal therapy, the results for clinical attachment level and pocket depth are significantly better, especially for pocket depths greater than 6 millimeters. The oral administration of moxifloxacin is still being evaluated for effectiveness. One study found that patients treated with 0.4% moxifloxacin gel had a pocket reduction of 1.5 plus or minus 0.6 millimeters compared to a placebo group which had scaling and root planing alone at 1.0 plus or minus 0.6 millimeters. The side effects of moxifloxacin include increased risk of tendinitis or tendon rupture, changes in sensation or nerve damage, or serious nervous system effects. Citalfloxacin is a new drug being studied in the treatment of adjunct periodontal therapy. Currently, it is being administered orally in 5 to 100 milligram dose twice a day. It effectively reduces AA to an undetectable level at 1 and 3 month reevaluations. So far, the effects seem to be similar to SRP alone. One study showed that citalfloxacin was the most potent against acute periodontal lesions among antimicrobials, and therefore may be useful in longer maintenance of residual periodontal pockets. Side effects of citalfloxacin include gastrointestinal disorders and liver enzyme elevations. What do you think? Is the addition of antibiotics to periodontal therapy effective? Can you think of a patient you have seen clinically that would benefit from antibiotics? If so, which antibiotic and which administration method? Do you think you will begin using antibiotics in your periodontal patients?